Welcome, everyone. Thank you for taking time and joining us today. So, brought to you by Foxy and Gastro Labs for the first time launched in India, bringing a revolution in endometriosis. Let me take a moment to introduce the convener and moderator for today, Dr. Komal Chauhan. Dr. Komal Chauhan, she is the medical director of Chauhan Maternity and Nursing Home, senior consultant at BN Desai Hospital, Mumbai, ex-honorary professor at Dr. R.N. Cooper Hospital and HBT Medical College, national coordinator FOXY for Medical Disorders in Pregnancy Committee, a member of the Managing Council MOGS, and there is so much more to her achievement. So, without further ado, over to you, Komal ma'am.
Yes, thank you so much. And at the outset, I would like to welcome you for a FOXY program on revolution in endometriosis. And when we talk about endometriosis, we always say it's an elusive endometriosis or an enigmatic endometriosis. And today we bring to you a CME focused on endometriosis. And this is an initiative by our president, Dr. Rishikesh Pai, Secretary General, Dr. Madhuri Patel. And I would first start with introducing Dr. Rishikesh Pai, who is the president of FOXY currently, founder and medical director of the Bloom IVF Group, chief administrator of FOXY Manyata Project, and also the group Society Liaison of FIGO, Women's Cancer Committee. He has been the editor of the Indian edition of British Journal of OBGYN and in the editorial board of Global Reproductive Health, board member of IVF Worldwide. Receive, I think, almost 100 plus awards, including the honorary FRCOG fellowship from the Royal College, and he has adorned hats in almost all the organizations, be it ISAR, IAG, MOGS, and even in IFSS. So over to you, Dr. Rishikesh Pai, to address the audience. And I would also like to introduce, before he starts, our two speakers, that is Dr. Niranjan Chauhan and Dr. Mark Noor. Dr. Niranjan Chauhan is a professor and unit chief of LTMMC, LTMG at Sion Hospital, organizing secretary of the forthcoming AICOG Mumbai 25, immediate past president of MOGS, that is the Mumbai Obstetrics and Gynec Society, joint treasurer of FOXY, treasurer of AOG, member oncology committee of CEPOC, and he has been in Dean ACOG, content director of HighGrad, editor-in-chief of famous JOG and TOA journals, many publications and awards to its credit. May I have the slide CV of Dr. Mark? And to join us, we have Dr. Mark Noor, founder, inventor, director of EndoSure Spark, and presently he is working there. He's a chairman CEO of the 3CPM, that is company Spark Glenoe MD, his present designation, director and CEO of International Foundation of the Global Health and Development, Digestive Health Education Foundation, Director and Chairman of International Institute of Study of GERD and Reflex-Related Disorders, Director and Chairman of Chinese American Institute of Study of GERD and Reflex Disorders, and Director of Endometriosis and Neuroenterology Research Institute, Director of the Heartburn and the Reflex Study Center, and virtual consultative and patient advocacy service therapeutic endoscopic physician trainer from 2019, co-director of the GERD and the Gastrointestinal Disorders Disorder Center, and the international consultant of GERD and Gastrointestinal Disorders, regional endoscopy instructor, Chinese Academy of Academics and Medicine, Beijing, China. So I think he has immense work in the field of gastroenterology and endometriosis, and we are really honored to associate with GastroLab for this webinar. So I hand over and welcome Dr. Rishikesh Pai, President FOXY. So he will begin the flow and address the audience.
Thank you, Komal. It's been a very good afternoon to everybody who is listening in, and I'm very happy today that we have got some wonderful speakers in our midst. Who will be talking to us on endometriosis. As we all know, endometriosis is a disease which affects all walks, right from the adolescent till the reproductive age group, women, as well as later on in midlife till the time of menopause. And it's really a burden to many It not only a burden to the individual person, but also the burden to society, because many manners are lost because of endometriosis. And I'm sure that whatever breakthroughs come in the future as well, which will try to alleviate this and cause an early diagnosis as well as an effective treatment, is going to go a long way in taking care and tackling this debilitating disease. So without much ado, I would like to welcome Dr. Niranjan Chavan, who has been our past, immediate past president of the Mumbai Obstetric Society, and he's also our, in the FOXY. He is the joint treasurer, and he's more important, the organizing secretary of the All India Conference in 2025. That is just around the corner. Not too many months remaining for that, just 1.5 years. So without much ado, and I'm also looking forward to this wonderful person, Dr. Mark, who has come all the way from United States to share his experiences with us on endometriosis. So we are looking forward to a very fruitful and interactive session on what's new in treatment of recurrent endometriosis, as well as what's new in the diagnosis, early diagnosis, and a different kind of diagnosis of endometriosis. So over to you, Dr. Niranjan.
Thank you so much, sir, for that kind introduction. Endometriosis is a common condition which we come across in various sites of the body. And it's an honor today that we have Mark Noer, a pioneer in getting this test launched in India. And I'm really thankful to Dr. Rishikesh Pai, our president of FOXY, and TOG, Science Integra, coming together on 1st May 2023 for this wonderful program, where I can see so many of you being there and listening to our program. We have endometriosis, which is found in so many places. Not only it is available and present in the genital system, but it is also present in various other organs. I would like to share my slide now. My topic will be on recurrent endometriosis. We have patients which we have endometriosis into the ovary, in the pelvis, in the omentum, in the sigmoid colon, in the colon, in the bladder, and in various other places for which we can diagnose MRI, we can use ultrasound, we can use FNAC, we can do CT and find out. And of course, laparoscopy. I'm going to go one by one. But there is a new tool which has come up, and that Dr. Mark is going to speak. But once we operate on endometriosis or do a medical line of treatment, still the patient comes to us with the recurrence of endometriosis. And that is what we have to understand. Sir William has said, the one who knows endometriosis knows gynecology. And if you do not know endometriosis, you are not a gynecologist. It's a very important clinical entity. I would like to go in the anatomy, physiology, and the pathology briefly about endometriosis. We are aware that it is basically a functioning endometrium which is present outside the uterine cavity. And the one which is present in the uterine cavity is an adenomyotic uterus. It was first described by von Rokitansky in 1860, and Stroin also has described it as early as 1600 BCE. Well, these are the various sites we find on endometriosis. You can see on the slide here, pelvic, extrapelvic sites, very rare in extremities and less common in other areas. And the prevalence of this endometriosis is about 6 to 10%. You have about 30 to 40% of infertile patients who come with endometriosis, treated, operated. We can also find endometriosis in multigravidas after the age of 35, having 2 children, coming back with endometriosis. That is surprising to see by us in the clinical settings. I would like to just briefly go through the histogenesis. These are the various theories we find: reflux and direct implantation theory, coelomic metaplasia theory, vascular dissemination theory, autoimmune disease theory, and there are other expressions of metalloproteins where there is overexpression and there is increase in P450. This slide explains us that it is an attack through all the aspects you find here, and that causes endometriosis. And then the worst scenario is the recurrence which occurs after 1.5 years, after 2 years, after 3 years, after 5 years, in spite of doing an initial conservative surgery or giving a definitive or a semi-definitive or a medical line of treatment. Even ACOG has expressed that the common site of recurrences again occur in absence of a uterus, even after doing a TLH in bowels. So it is very important that the first surgery is a very important surgery. The initial surgery has to be a classical one. It has to be appropriate. It has to be full. Otherwise, the patient again comes back with recurrence, and a repeat conservative surgery has to be done. And then the range of the recurrence is 20 to 40%. In spite of doing a very good laparoscopic cystectomy, you will find that an endometrioma has again reoccurred after a few years. So it has to be understood that the first surgery has to be the best one. The symptoms are similar to that of endometriosis. What you find initially, those are pelvic pain, dyspareunia, vaginal and rectal bleeding is a worst scenario, low back pain, and painful defecation. Symptoms are here also written. You can go through it, but most importantly, there are painful bowel movements. If it is in the rectosigmoidal plate, if it is in the vaginal rectal plate, it is going to cause a very painful amount of bowel movements and affecting the total psyche of the patient. You have patients who are anxious. You have patients who are always nervous. You have patients coming with every monthly this issue, and they cannot bear it. So you have to understand that in spite of the best surgery, there are certain issues. Why we have recurrence? Why? They are not seen by the naked eye. They are the deep endometriotic lesions you can find in the rectovaginal plate. You have done a very good surgery, but they recur again, especially in the subperitoneal spaces. There are certain atypical and non-pigmented lesions which you find here. They are not the typical brownish or powder burn marks. You will find it as a whitish color, as a pinkish color, as something different which is there apart from endometriosis. They can be red, there can be red-yellow, there could be defects, there could be black or blue color, which is endometriotic spots. The lesions are hidden by the peritoneal adhesions. So many times we have done a laparoscopy, we find that the whole of the pouch or Douglas is obliterated. The ovaries cannot be seen. The ovaries are kissing ovaries. But you find that the sigmoid is there on the left-hand side, and the mesentery is also stuck up on the right-hand side, and there is nothing which you can do. There are all peritoneal adhesions. It's a grade 4 endometriosis, and in spite of the best clearance done, you have recurrence coming back. There are also literature which says that hormone replacement therapy is one of the cause, and there has to be a good importance of removal of all these deep lesions. Microscopic foci of the disease, they further progress into a clinical significant disease, and that is why we have recurrence. And of course, there is a lymphatic spread which occurs, and you can find a reported involvement as up to 25 to 40% of rectosigmoid endometriosis. So it is not just a clean-cut endometriosis, but a recurrence of all these causes. Well, you do a TLH, you do a hysterectomy, you keep that ovary, and those patients again come with an ovarian preservation surgery done, and they have a high fold of risk of recurrent pain up to 6.1 and a reoperation up to 8.1 fold risk. So these are all the causes you have to understand. There is an ovarian remnant syndrome where the recurrence of endometriosis occurs in spite of the oophorectomy which has been done. Now we come to the important diagnosis. We have this patient coming back to us. We have the latest X-ray guidelines, and they recommend that the diagnosis has to be done on based of the symptoms and non-gynecological symptoms which are displayed here. And of course, the most important is the mapping of the pain and the physical examination, the abdominal examination, the per speculum examination, the per vaginal examination. You can find the nodularity when you do a PV examination. The cervix is downwards and backwards, and the uterus is retroverted. It cannot be lifted up, and you find the nodularity into the uterosacrals. And if you put your fingers further laterally, you will find ovarian endometriomas. So these are all the diagnostic features you have to do. And in absence of evidence during examination is not an evidence of disease absence. So what to do? We have an ultrasound, transvaginal sonography. We have the ground glass echogenicity, which we find a typical ground glass. You can further do an imaging study, and you can also see that endometriosis is not only confined to the genital organs, but it has gone beyond. It can be also seen in the ileocecal junction on the left-hand side, and you can see on the right-hand side also the appendix suggestive of endometriosis. Well, MRI, the tool is available, and it can detect even the smallest of the lesion. It is superior to the CT scan, and it can detect even endometriosis in between the muscle and the abdominal subcutaneous tissue. You can also access the uterus, the bladder, the bowel involvement, and you do not need any additional imaging like barium enema or further sonography to be done, or a transrectal sonography. This picture will speak for itself. You have A, B, and C component. The A component is where you can see the uterus, which is anteverted, and there in the rectovaginal plate, you can find a deep endometriotic lesion, which is there in the small arrows. But also at the top of the bladder, you can see a long arrow, and that is what you can see in endometriosis, which is hidden. You cannot see even by laparoscopy. This is what you can find on an MRI, and you can do a surgery, a definitive surgery to go ahead. You can see in B, the sagittal and the coronal sections. Thus, we come to the diagnosis of laparoscopy. We used to do the laparoscopy. It was a gold standard. And then we used to detect endometriosis onto the uterine surface, the ovary, the peritoneal aspects, the uterosacral, the adhesions which are there. And then we used to do a definitive surgery. But laparoscopy is no longer the diagnostic gold standard as per the ESHRE endometriosis guidelines. It is only to be recommended in patients where the imaging results and or where the empirical treatment is unsuccessful or inappropriate. So we still have to change our mindset. We need to change our mindset. We have to understand this is the least function LF score at the conclusion of the surgery, which will tell us the fertility and post-surgery betterment in the management of endometriosis. We always follow the American Society for Reproductive Medicine classification. It stages endometriosis from stage 1 to 1-4. Whenever do a laparoscopy, we have to have the diagram, and you put those marks onto the ovary, onto the uterosacrals, onto the bladder area, further adhesions between the ovary and fallopian tube. And then further, as the stage increases from mild to moderate to severe, you find even the obliteration of the cul-de-sac. You find deep endometriosis, kissing ovaries there, and the whole of the obliteration. You cannot see the pouch or a Douglas. You cannot see the rectovaginal plate. And there you find the totally severe grade 4 endometriosis. So we need to do a surgical management in such cases. We have already done before, but now we need to understand to do a definitive surgery if she has completed her childbearing and she has pain, she has endometriosis, TLH, or an open surgery, total abdominal hysterectomy with bilateral salpingo-oophorectomy, with excision of all the endometrioma or endometriotic spots, whichever you are seeing with a naked eye, onto the peritoneal surface, anywhere, and lysis of adhesion. A definitive management is the most optimum thing if she is more than 35-40 years and has completed the childbearing age. But a semi-definitive procedure will be given to patients who are still fertile, who want children. They have to be preserved with an uninvolved ovary. However, there is a 6 times increase in the risk of recurrence and 8 times reoperation rate, which we need to explain to our patients. So basically, when you go ahead and do a management, a definitive management or a semi-definitive management, you should see and treat and then go ahead to do this laparoscopy. Cystectomy is the best option. A proper cystectomy with proper peeling of the endometrioma and doing a proper irrigation, also proper fulguration is very important. Worst scenario, you might have to do a Luna or to do a pre-sacral neurectomy if the pain is there. So that you will have to do with a surgical involvement faculty. Now I would just go to one of the case reports, 28-year-old. She came to me, married since 9 years, severe pelvic pain, severe dysmenorrhea. She had undergone a history of laparotomy with a right ovarian cystectomy 4 years back, with an ultrasound now showing 7 into 6 into 4.5 centimeter, which is showing a ground glass echogenicity and most likely to be a chocolate cyst. This is what a picture is there. We go ahead and do a definitive treatment, a removal of that ovarian endometrioma, or rather a semi-definitive treatment, and we reduce and remove that either by laparoscopy or an open surgery, whatever the best option is there. The second case report is 47-year-old nulli gravida with symptomatic adenomyosis, which is posted for a TLH with BSO. Intraoperative, the uterus was bulky, adenomyotic, 8-week size. There is an evidence of grade 4 endometriosis and bilateral tubo-ovarian mass with sigmoid colon and rectum adherent to the posterior surface of the uterus. I have a video. I will show it at the later half if the time permits. But this is what you need to do: a surgery, a TLH, and BSO, either an open or a laparoscopy. Post-surgery, it is very important. But some of the patients also require a pre-operative medical line of treatment. And the idea, you have to understand and individualize a properly individualized assessment. You have to induce amenorrhea. You have to create a hypoestrogenic environment. And the drugs which can be mentioned here is Dynogest. This is the new kid on the block. It is 2 milligram once a day given for 3 months. And you can give it at a very longer period. You can give up to 9 to 10 months, take a break of 1 or 2 months, and again give. And there are studies even that Dynogest has been given for 5 years. So that is just to tide the crisis away, and the patient is better off with pain symptoms and much better during her periods. OC pills were also recommended. In my time of residency, we used to give danazol 200 milligram 3 to 4 times a day for 8 to 9 months. But the better drugs available is leuprolide. There is GnRH agonists. They cause pseudomenopause state. It causes, however, osteoporosis. So you need to give an add-back therapy in such cases. There is also aromatase inhibitors, and they are the preferred drug in deep infiltrating endometriosis. And of course, Mirena, medroxyprogesterone acetate, NSAIDs can also be added in this treatment. So you have to understand this is a medical line of treatment, a surgical line of treatment of definitive and semi-definitive, and also you have a pre-operative management where you can give this patient GnRH agonist or Mirena, and then that reduces the endometriosis associated dyspareunia, the menstrual pain, and then you can go ahead. But there are no trials that compare the hormonal suppression of endometriosis before and or after surgery or with surgery alone. Post-operative management is also very important, and we have to give this so that it causes a hormonal suppression of endometriosis. But there are no benefits which have been found in the studies. The available literature strongly supports that the benefits of prolonged amenorrhea after the surgery is helpful in preventing recurrence of endometriosis. So we have two schools of thoughts where you can give and where you cannot give. But if you ask me personally, after a surgery, I would prefer to give a post-operative medical line of treatment. Then there is something like secondary prevention. What do you mean by secondary prevention? It is defined as an intervention to do prevention of recurrence of pain symptoms or the recurrence of disease for a long term. And it is defined of more than 6 months after the surgery. This choice of intervention depends on patient preference, the cost, and the availability and the side effects of the drug. So now, when we come to endometriosis and the management, there are certain recommendations which are given, and that is the studies on GnRH antagonist. The treatment supports their use as a second-line treatment option, and even the recent data indicates that the post-operative medical treatment may be beneficial towards the pain management and support a recommendation of offer to women not desiring immediate pregnancy. So secondary prevention is also there in 2014 guidelines. Well, after cystectomy for ovarian endometrioma in women not immediately seeking conception, clinicals do recommend a combined hormonal contraceptive for the secondary prevention of endometrioma. And this is also in the form of an LNG IUS, which can be given up to 18 to 24 months. So this is you have to understand that secondary prevention has to be done so that you do not get recurrence. There are endometriosis and infertility. We have 20 to 40% of women with endometriosis. They come back. There is a lot of research on that and going on the management, recurrent endometriosis and infertility. Well, in such situations, it has been proved now that IVF, ICSI is a better option. And of course, the ESHRE guidelines also suggest that there is an extended administration of GnRH agonists prior to ART treatment, and that improves the live birth rate in infertile women. Endometriosis fertility index also has been added as a step in the treatment which can support the decision making for the most appropriate option for pregnancy after the surgery. This is the endometriosis fertility index. It takes into account the historical factors which are mentioned here on the left-hand side, which includes the age less than 35, 36 to 39, and if the age is more than 40 years, you have certain points. You have to also give as per the years of infertility, less than 3 or more than 3, prior pregnancy is there, and that total historical factors are then added with the surgical factors, which denotes the LF score, the AFS endometriosis score, and the AFS total score. And this, when added, will give an EFI, a proper score, and that will decide how best you can manage these patients. There are also availability of CO2 laser vaporization for endometriosis instead of the monopolar electrocoagulation, and it has much better cumulative spontaneous pregnancy rate. So you have monopolar cautery, you have laser, you have fulguration, and you have cystectomy, which you do with this. But it is very important that if you have a laser, the chances of fertility are much better, and it preserves the ovarian endometrioma. Approximately 0.7 to 1% of patients with endometriosis lesions will undergo malignant transformation, and you have to understand that this is a endometrioid adenocarcinoma. This is a famous personality which also had endometriosis, especially when she was campaigning for her presidential election. In conclusion, the recurrence of endometriosis is fairly common. The first surgery to be done is the best surgery, and the best surgery to be done in the best hand, the skillful hands, either by endoscopy or by open surgery. It will reduce the rate of recurrence. However, there are still going to be lesions which are going to come back, and that can be as high as 40%. But the most common reason is incomplete resection, because there are certain microscopic foci which escapes detection. There are deep endometriotic foci which are not seen by the naked eye, and they are still embedded, and they come back. And that is what the recurrence is importantly there. And that's why we need to do a secondary prevention by giving a medical line of treatment. Laparoscopy remains the gold standard for India, but as far as the ESHRE guidelines, it is no more a gold standard. So you need to change your mindset. You need to change the mindset and also go ahead to do a proper operative endoscopic surgery rather than just doing a diagnostic endometriotic surgery. A combined surgical approach of a laparoscopic laser or a monopolar, adhesiolysis, and a uterine nerve ablation is very beneficial for pelvic pain, and it will help to be reducing the pain symptoms and all the further recurrences to occur. Medical management can be given preoperatively, but the post-operative medical management is also to be given thought, especially when the patient doesn't want fertility. You can still continue the medical line of treatment. Interventions are there which may be required, and it is important that it can be given more than 6 months after a surgery has been done. These are my references, and I would like to thank all of you, especially Science Integra and Foxy, to get me on board on this wonderful 1st May, the Labor Day, or the Maharashtra Day, or the Gujarat Day, which we celebrate since time of independence and since the independence in 1960 of Maharashtra and Gujarat state. Thank you so much for a patient hearing. I end my talk here.
Thank you so much, Dr. Niranjan Chavan. It was a very elaborate presentation about the recurrent endometriosis and the management, highlighting the surgical aspect so well. And there are so many messages coming in the chat box, appreciating your talk and other things. And there are a lot of questions also. So questions specific to the management. There is a Bhagalpur. What's the role of dydrogesterone in modern methods of treatment of endometriosis, and how far it is feasible and helpful to our patients?
Well, dydrogesterone is a miracle drug. It is used in RPL, it is used in pregnancy, it is used in antenatal period, it is used in endometriosis. So the best is option you have to decide. But of course, Dynogest, Dydro, both are like brothers and they can go hand in hand. You can choose the right drug and that can be given also for a secondary prevention and also for primary endometriosis. Today, if your patient is having pain with periods, pain in the pelvis in general, or a pain with intercourse, urination, bowel movements, all of that may point us to a suspicion of endometriosis. But unfortunately, the only way to say 100% that if your patient has or does not have endometriosis is to do an MRI or an ultrasound or FNAC, or you have a CT, or the best modality is an endoscopic view, a laparoscopic. But wait, we need to seriously believe that there is some good news which is coming, and it is in the next session. And that is what I would be very glad to all of you to go ahead and get Dr. Mark further to this program following my lecture. I'm very eager to hear. India is very eager to hear that this is the first time a launch has been occurred in India. And I'm really grateful to Dr. Rishikesh Pai and Science Integra and GastroLab, which is going to come up with this modality. This is going to be the game changer. This is totally going to change the whole perspective of how you would diagnose endometriosis. Welcome, Dr. Mark.
Thank you very much for that wonderful introduction. It is a great honor for me to be able to be here and to be able to launch this product here in India. This has been a life-changing product for me, as it will be hopefully a life-changing product for everyone who is involved. Now let me share my screen. Hold on, we're just having a technical difficulty here. There we go. All right. I have to quit and reopen.
Yes, I think Dr. Mark will be joining soon to present his talk. And we have a lot of congratulatory messages in the chat box for the webinar, congratulating Dr. Rishikesh Pai, Dr. Niranjan, and Team Science Integra for this wonderful webinar. And there are all questions all related to the recent advances. And I think most of the questions would be answered after an elaborate talk by Dr. Mark. So over to you. Please join back.
I am back.
Yes.
All right, let me go ahead and share my screen. All right. Okay, great. Everyone can see that screen perfectly? Yes. Wonderful. So today we're going to talk about a new development that's come along. I shouldn't say new, it's actually quite old, but we've been able to finally launch this product. I want to be clear that first, what we are talking about is electroviscerography. This is a regulated medical device that is meant to detect the myoelectrical activity that is given off with contraction of the smooth muscle anywhere within the abdominal cavity, be it abdominal or related to the gastrointestinal tract, the uterus, the fallopian tubes, or even the urinary system. But in this particular case, it's mostly the small bowel contractility that is abnormal in endometriosis. And this is married with what we call a clinical decision tool, which is the AI-derived threshold score of that intra-abdominal myoelectrical activity that helps us to predict the presence as well as the spectrum of disease of endometriosis. You can see my disclosures as well as my credentials there. This all began in 1998. So many of us who have been in practice for long enough become what I call medical archaeologists. We go back into the literature and we find all of the things that we should have known but didn't, because medicine advances at such a rapid rate. This is a colleague of mine. This paper was published by Dr. John Mathias and the surgical colleague, Robert Franklin, who was a well-known surgeon in the US a number of years ago. And what
Dr. Mark,
yes.
Mark, may I request you to please make it full screen? We are able to see two slides together.
This is
share the entire screen.
Yeah. It is shared.
Let me stop sharing.
All right, let me stop sharing.
Dr. Mark, there is a use slideshow on the left-hand corner. If you press that, yes.
Got it. Okay, thank you.
Yeah, welcome.
So this paper was printed and published in the Fertility and Sterility in 1998 by one of my colleagues in gastroenterology, who discovered that endometriosis created a particular neuromuscular problem in the gastrointestinal tract, and that led to the insights for the development of this particular device. And he found this was not only this was exclusive to endometriosis, but he also found the etiology that he published in this paper, and that is very, very simple. All endometrial tissue, no matter where it is located in the body, produces very significant amounts of PGE2 and PGF alpha, regardless of location. And these neurotransmitters are absorbed into the tissues, carried through the bloodstream, and as they then have an influence on the small intestine, creating a seizure-like spasm that produces abnormal small bowel myoelectrical activity that has been found to be unique to endometrial tissue. And that is what is detected by the EndoSure test. And again, it doesn't matter where the endometrial tissue is, the same effect is seen. This is all mediated by the pathophysiology is mediated by the ICCs in the smooth muscle. These are the keys to motility. And you'll see the ICC cells are here interfaced between the myenteric neurons and the smooth longitudinal and circular muscle. And it is these ICCs that control the normal contractility of everything that's smooth muscle, whether it be the small bowel or the uterus. These were discovered by a Spanish physician, a famous Spanish physician anatomist, Ramon y Cajal, for which he received the Nobel Prize in Medicine in 1907. He's the only Spanish physician to have ever received a Nobel Prize in Medicine. And these are your pacemakers. So in the gut, this keeps the stomach contracting between 1 and 10 cycles per minute, and it keeps the small bowel between 10 and 15 cycles per minute. In the GYN organic organs, this is also hormonally influenced, the uterus and the fallopian tubes normally at rest, when not stimulated by hormone therapy, contract at 1 to 2 cycles per minute. The uterus during menstruation or during birth kicks up to about 5 to 8 cycles per minute. And the fallopian tubes during ovulation will go as high as 8 to 12 cycles per minute to promote propagation and movement of the egg through the fallopian tubes. But what happens is when you add PGE2 and PGF alpha, it gets in the way of the normal contractility of the bowel, and you have spastic opposing contractions, which is the result of the uncoupling of these ICCs. And this occurs in what could be easily understood as a drug dose response curve pattern, which is to say the more endometrial tissue and the more active that tissue is, the stronger the reaction is and the stronger the signal that we detect. Similarly, the more you suppress the disease, the less disease there is, then it's going to be a slightly smaller effect. What we're talking about are uncontrolled small bowel activity in the 15 to 200 cycle per minute frequency. More particularly, the very, very specific frequencies are 15 to 25, 30 to 40, and 50 to 60. And this is what's very unique to endometriosis. This is the individual fingerprint. In 2007, Dr. Matthias came to me and he said, you know, you've already gone ahead and created one device in the gastrointestinal system to help look at gastrointestinal motility. And could you do this in the GYN system? And as I looked into endometriosis, I found it was so compelling that I immediately turned around, and it took me about 2 weeks to go ahead and figure out how to rewire and reconfigure the device so we could detect this activity. And what was important is not only could we detect the abnormalities, and this will be important to further discussion, is we can see when it goes back to normal, giving us the possibility to not only see to detect the disease, but to detect when we've done something positive to modulate the disease. This is the device itself. It's actually quite simple. There's a respiratory belt that goes above the clothing, above the breasts. This is a stretch sensor so that the machine knows when there is respiration at 25 cycles per minute, as opposed to contraction of the bowel at that same frequency. The device itself is this small box here, which is the size of 2 cell phones on top of each other. This is what does all of the detection, all of the filtering, which is then sent to the computer for analysis. With that are these proprietary electrode pads. Now, we're all used to the standard electrode pads with the 1 centimeter circular diameter area of wet gel in the center, which are effective for cardiographic uses, but we need to be able to sense much lower frequencies. So these pads are capable of sensing across the entire 4 centimeters. They are dry gel pads. And the reason for the dry gel is that it eliminates artifact and it allows us to sense down to these lower frequencies. Now, it's 4 centimeters across the surface of each pad, but these cone out to about 20 centimeters in the intra-abdominal and intrapelvic area. So we are essentially sensing this signal from pubic symphysis to xiphoid process using these proprietary electrodes. The test itself that powers this is a very old test that's been standardized through the literature. It's called the water load test. And what we're doing is we're activating the contractility of the bowel to bring out these abnormal frequencies caused by the presence of endometriosis. After a 6 to 8 hour overnight fast, the electrode pads are placed on and left for a period of 10 minutes. The device is then connected, the belt is placed across the chest, and after a baseline period is obtained, the patient is asked to drink water until full. That's just plain water until they feel completely full. This takes approximately 2 to 3 minutes, after which the patient remains in a reclining position and we gather 30 minutes worth of data. At the end of that time, that data is sent to the computer, the analysis is done, and you have a diagnosis, yes or no, for endometriosis. So again, this is a 30-minute diagnostic test for endometriosis. This is to give you an idea of the contractility that we're talking about and how the graphical representation is. This is what a male would be. When we initially started doing this, no one had ever looked at these upper frequencies using this particular device. And so we studied men and women. We studied more than 3,000 or 4,000 men and women with all types of diseases because we needed to see, were there other diseases that caused similar problems? The area really that we're concerned about is this area from about 15 all the way up to 60 cycles per minute. This happens to be the example of a male. Here is a female patient. And again, in this area of 15 to 60 cycles per minute, we don't see really anything but very little bit of random activity. So this gives us our baseline and enabled us to calculate what normals were, for which we could compare abnormals. And this is what we talk about when we talk about the unique fingerprint of endometriosis. Now, here's that same normal graph in the upper side of the diagram. And here you can see this 15 to 25, very, very prominent set of peaks. Another set here at 30 to 40, and another set over here at 50 to 60. This is that unique fingerprint. There is no other disease other than one caused by endometrial tissue that gives this type of activity, fingerprint in the small intestine. So yes, that means not only endometriosis will do it, but so will adenomyosis. And this is what we detect. Now, of course, it would be impossible to release a device that would require physicians to look at lines like this, curves like this, and to make a diagnosis, because inevitably there would be arguments. People would be turning their heads sideways and squinting their eyes and arguing about what was positive and what was negative, nor can we determine sensitivity or specificity from looking at a graph. And so what you do then is you look at the numbers which represent the power of the curve under the graph. And that's what you do. And when you do that, here's an example of the difference. Your bottom row here is the normal patient. Your upper row is an endometriosis patient. And if you look at these signals, you can see a striking difference of a 40 to 80-fold difference here in this particular column, similar fractional increases in those others. So that's the difference between an endometriosis patient and a normal patient. Very, very different numbers when we look at that percent of power under the curve. So that gives us the ability to now do the statistical analysis and run our study. And that's the study that we designed, which is 154 patients. We have cohort 1, which is our non-endometriosis normal cohort. This was combined of healthy, normal, asymptomatic women, as well as women with abdominal pain without endometriosis caused by IBS, IBD, biliary, or urological origin. Now, I mention these diseases because when we studied our 3,000 to 4,000 patients, we studied specifically women with IBS, IBD, biliary tract disease, gallbladder disease, pelvic inflammatory disease, polycystic ovary disease, as well as urological diseases such as infections and interstitial cystitis, all of which have been confounded with endometriosis. So we included them in the study because we also determined that they do not have that specific fingerprint. Cohort 2 is what we would call the gold standard cohort. These are women who underwent laparoscopic evaluation, were found to be positive for endometriosis, some with excisional biopsies, but none with full therapy. And they underwent this particular test after they had undergone their surgery. And cohort 3 are our proof of concept or our validation cohort, which were women who were coming in preoperatively for evaluation who had suspected endometriosis with plans for laparoscopic surgery for diagnosis. And this was all done under the auspices of the Women's Hospital of Texas, IRB. Now, when we look at the demographics between all of our cohorts, the thing that stands out is cohort 1, which was the endometriosis-free cohort, had significantly less pain than those of cohorts 2 and 3, which were our endometriosis patients. The only other notable difference here is that in the cohort 1 group, there were no Asians, but the other ethnic groups were equally represented across the cohorts. And BMI had no influence at all with regard to demographics, nor the results of the test. Now, remember, I had mentioned we used a blended cohort of healthy normals, or rather endometriosis-free normals, which were combined with healthy normals as well as those who had no endometriosis but pain from other causes. And so when we do our statistical analysis, we wanted to be sure if we could combine them together into one group. So we wanted to see statistical homogeneity. And in fact, there were no statistical differences between these two groups. And so they make our non-endometriosis normal group. The numbers are 62 patients were in cohort 1, none of whom had the qualitative pattern for endometriosis. In cohort 2, our gold standard group, all 43 of the enrolled patients had that positive pattern for endometriosis. And in cohort 3, there were 49 women, 47 of whom had the specific fingerprint pattern for endometriosis, 2 of whom did not, who then subsequently went to surgery. And we had 47 of 47 who were positive for our test demonstrated endometriosis at laparoscopy, and the 2 who were negative were also negative at the time of laparoscopy. We're giving us a 100% concordance with surgery. We will comment more about that 100% accuracy rate later. All 4 ASRM grades were represented in this group, of course, with a predominance of grades 3 and 4. I will also mention that all of these women were on hormonal therapy for a minimum of 3 to 4 months, which was either birth control pills, a Mirena type uterine device, intrauterine device, or gonadotrophin axis blockers. When we compare the results, the area under the curves compared to our non-endometriosis cohort 1 to cohorts 2 and cohort 3, as you can see here, we see significant differences between our non-endometriosis and our endometriosis cohorts. What I do not have here, which is in the paper that is being reviewed at this time by the Obstetrics and Gynecology Journal, is the comparison between cohorts 2 and 3, which were statistically similar. So no differences between the 2 endometriosis groups. So once you have findings like this, you then decide it's time to go ahead and do our sensitivity, specificity, and predictability calculations. So we use that area under the curve, which is the classic statistic that you will use for predictive probability. We test this at all frequency levels, as well as at all sampling levels at 0, which is baseline, 10, 20, and 30 minutes after the water load. We use a logistical regression analysis to estimate the predictive probability of endometriosis using AUC as the main covariant. And this is something that you would typically do, especially if you're going to use AI in your calculations. You need that logistical regression analysis. We will then employ other variables such as age and pain symptom score to improve predictability, again, using that as part of the AI-derived formulation. Another important point to note, just like when you calculate what numbers do you need to achieve statistical significance or to be able to say that you had enough power in your study, the power calculations for this study required 30 patients per group, which we exceeded at all levels. But for when you're using AI, the similar question is, what qualifies you to use AI and to be able to use it successfully? And so there are 2 factors that you have to keep in mind. And one is that you need a current factor value of at least 0.5 or higher, which is what we set ours at. So that's 0.5 for the women to be diagnosed with endometriosis or to be endometriosis free. The other category is you want to have a 1 to 10 factor for every variable. So we're studying 3 variables. We needed to therefore have 30 women per group, which we again succeeded in having. So we validated our use of artificial intelligence in our calculations. We then estimate the sensitivity, specificity, and predictive values. And one other thing I happened to notice when we were running through the data, and that there was a difference in the results. There's about a 4% variance in women who are 35 and under compared to those who are 36 and older, likely due to the falling off of estrogen production if 36 and older, in the 36 and older group, especially in this estrogen-dependent disease. Now, when we look at our predictability, the classic way you do this is you look at the area under the curve ROCs, and you want to get as close to the value of 1 as you can, which means that you want your data grouped up into that left-hand part of the diagram as much as possible. And in the age 35 and unders, we're at 0.9979, pretty close to 1. And then for our age 36 and older, remember there was a small variance, and we're at 0.9847. Again, very statistically significant in terms of our predictability. once you see values like this, you get very excited because you know that you've got a test that's going to be extremely successful. So now when we go ahead and we take a look at our quantitative values and look at our sensitivity, specificity, and importantly, the C statistic. Here are all the different permutations that we had the artificial intelligence programs run through. And we settled on using the area under the curve for 30 to 40 cycles per minute, 40 to 50 cycles per minute, as well as the pain symptom score, giving us a 95% sensitivity, a 96% specificity. And very importantly, so the bad news is we're no longer at 100%, but we're at 99+% in terms of our predictability. So the C statistic briefly just means what is the probability that a woman will have endometriosis if her test is positive. So again, that's 99+% for those who are age 35 and under. Now, one thing I want to direct your attention to that's very important is that you'll notice here in the group, the 25, you're using the area under the curve for the 15 to 20 cycle per minute plus pain symptom scores. We had very similar results in terms of sensitivity, specificity, and the C statistic. So one would ask the question, why didn't you just use the simpler formula? And there's a very good answer to that. Remember now, we wanted to make sure that we weren't going to have any false positives, so we had to exclude other diseases that could interfere. And biliary tract disease or gallbladder disease comes in at 14 to 18 cycles per minute. And that would be a confounding factor. So knowing that we did not want to have a false positive diagnosis of endometriosis in someone with gallbladder disease, we chose to exclude those frequencies from the analysis and still ended up with a very, very respectable sensitivity, specificity, and C statistic. Now that's the 35 and under group. Let's take a look at the 36 and older. Remember, I said there was about a 4% variance. And so you'll see here that our sensitivity drops from 95 to 91%. Our specificity goes from 96 to 95%, and our C statistic drops from 99+ to 98%. Still very, very healthy predictability using this particular test. So where are we at the end of the day, having completed the study and run the analysis? One more thing to tell you. So how is it that we actually tell you a patient has endometriosis? And this is that clinical support tool, the AI-based calculator. So what you get at the end of the day is you have this calculation device and you will insert the 30 to 40 cycle per minute numbers here in these columns representing 10 minutes, 20 minutes, and 30 minutes after water load, the patient's age, as well as a GI symptom score, which is a modified Endo 4D standardized published pain scoring system. And then it does the calculation, and you then look down at the age group, and this particular patient is 43, so she's greater than age 35, and you look at the p-value that is derived, which in this particular case happens to be 0.18, indicating that this woman likely does not have endometriosis. Now, there is a chance, we've not seen false positives, but there is a slight chance that you may have false negatives. And so we use a secondary calculation that is very sensitive to make sure that this is a true negative as opposed to a false negative. And this also gives us a variable score. And so we call that the severity index calculation. And you can see here, her value is 0.2883386. It has to be 0.5 or higher in order to have endometriosis. So her severity index is very low. And this confirms she does not have endometriosis. And so this calculation is automated by simply putting in those several numbers that I spoke about in the beginning. And we have found that these numbers that you get calculating out of the severity index happen to be corresponding to the ASRM surgical stage. So therefore, this is our severity index that appears to calculate in concordance with the surgical stage. Now, there are some caveats, and that is the coexistence of adenomyosis and endometriosis will influence the score. And so in order to have it correspond to surgical stage, we have to do a slight surgical stage adjustment when adenomyosis is found concomitantly. What does all that mean? Well, when we take it out into the field in a clinic like one of yours, and you have 9 patients in this particular case at a large MIG center on the West Coast of the US, there were 2 normals, and you can see here those 2 normals. at the top, and number 1 and 2. And then 3 through 9 are all patients who are going to surgery within 2 or 3 days. And the thing that you'll find remarkable is that the stage 4s, the grade 4s, all were at the 0.9 or higher level in terms of our scoring system. The grade 3s were the 0.7 to 0.9 to just below 0.9, and the grade 2s were 0.6 to 0.7, and grade 1s, which we have in other studies, are all in the 0.5 to 0.6 range. So we appear to have a tool that not only tells you yes or no, you have endometriosis, but is able to tell you the intensity or the severity of the disease. So at the end of the day, qualitatively, we were at 100% sensitivity, specificity, and surgical concordance, but we're no longer there. When we look at our quantitative values, again, at age 30 for the 35 and unders, greater than 99% predictability. For age 36 and over, 98% statistically, statistical predictability. And I want to, again, reemphasize that these results were unaffected by whether the patient was on hormonal therapy or what the surgical grade, was being represented. So what do we have? An accurate screening tool that works from menarche to menopause. We've tested this on young menarcheal women at age 11 and 12, and it does the exact same thing. So it's not age dependent. It's objective evidence. It suggests, because we can detect when things normalize because we have the severity score, that this may be the long sought after post-surgical treatment monitoring tool that we I think have all been hoping for. It'll likely change our diagnostic algorithms in the infertility world, where 40 to 50% have endometriosis, and you can pick them out immediately before you begin any other therapies. In the pelvic pain clinic, the 30% that don't have it become important because they get treated differently. And of course, the ones that are the most important to me are the adolescent screening populations, where we have 45% and 50% respectively endometriosis and dysmenorrhea in adolescents and young adults. So we also have an ideal screening tool. It is, I'm going to emphasize, is complementary to current anatomical staging. It provides a graduated activity index, and I believe what we are doing is reflecting not only whether the disease is there, but the spectrum of the disease activity or burden, and again, giving us the possibility for post-treatment monitoring of effectiveness. And there's also some evidence that I have not presented, that with effective medical treatment, with suppression of symptoms, we see a decline in the activity score. So it might be, again, that tool that will tell us, did we hit our important points of suppressing the endometrial tissue even with pharmacologic agents? And finally, new drug development and testing has been impeded by the fact that the gold standard has been considered surgery for forever now. With a test like this that is easy to use and it can be done anywhere, we already have pharmaceutical companies knocking on the door asking if this can be used in their evaluation of their drugs that are in the pipeline. The test itself is very low cost and portable. The consumables are well under $50. It's a resource non-intensive. This is not done by a physician or even a nurse. A medical technician would do these, so you need low technical skills. There are no biologicals here. We don't require any laboratory services. So there are many other tests out there. We don't need saliva, urine, blood, uterine scrapings, menstrual fluid, or tampons that the woman wears for 2 days and then get analyzed. This is strictly 3 electrodes pasted on the abdomen and a computer with a glass of water. What we have done is we have effectively decentralized the diagnosis of this disease. No longer will anyone who is limited by geographic location or financial discrimination not be able to have a diagnosis of endometriosis. So literally anyone in a small village on the side of a mountain or in the middle of a desert, if they have access to a computer, potable water, and this device, will be able to have a diagnosis for endometriosis. And I believe that is my last slide, and I thank you very much.
Thank you so much, Dr. Mark. I think it was a revolutionary technique which you have showed us, and it has opened the new Pandora's box in management and early diagnosis of endometriosis. There are so many questions coming from the audience who are really very curious to know about it. And Dr. Nandita from Mumbai is asking, can you actually diagnose a mild, that is the early stage endometriosis with this?
So the answer is yes, and I will tell you when we released this device in Europe a few weeks ago, I was in Denmark, and they of course presented some very difficult cases to test out the system. And one lady was a 45-year-old who had had 5 surgeries for endometriosis. She had quite extensive endometriosis at one time, was status post hysterectomy, salpingo-oophorectomy, as well as excisional biopsies, but they did not tell me. They blinded me to the results of her last surgery, and they had the test done. Now, her activity score was 0.052, which is very, very low. 0.5 is the entry point for positive for endometriosis. And I turned to the surgeon, and my comment I made was, I don't think you need to tell me anymore what happened. You left behind a small amount of disease, and we've detected it. And in fact, what they left behind was 2 2-millimeter lesions that they left on the colon because they didn't have permission to do a bowel resection at the time of her last surgery. So we can detect down to minuscule amounts. And I will tell you, it doesn't matter that it's in the abdominal cavity either. There was another woman who I recently was able to do, who had excisional biopsy. They felt that they got all of the endometriosis, and her test was positive, remarkably positive, with a score of 0.86. And so in discussing this with her surgeon, the answer was, well, you got it all, but it means it's somewhere else. You need to look transthoracic. You need to look in other places. And I said, let's just ask her a few questions. And one of the questions I asked is, have you had any problems in the last year or so with any joint swelling or stiffness that you didn't have before? In fact, she complained of swelling and stiffness in her left knee. And so we directed them to go ahead and get an x-ray and then call the orthopedic surgeon, who went in and resected the endometrioma in the joint space of the left knee. So we're even able to detect extra abdominal, extra pelvic disease down to very small amounts.
Yes, so I think early diagnosis is possible. The thing which comes into my mind is that will we be able to know the severity of the disease by this technique? Like, we can diagnose the presence of endometriosis. Will we know the advanced recurrent endometriosis, or deep infiltrating endometriosis? Will we know what stage we are managing?
So far, the preliminary data suggests that we are tracking with the ASRM stage. Now, we have not gone against any of the other staging systems, and we can easily do that. There are some caveats, and again, this comes from the experience in using the test over the past 3 or 4 months. There was one patient who I had indicated probably had stage 4 disease, and at the time of surgery, the surgeon came back and brought his films with him, and she clearly had stage 2 disease based on the ASRM system. And so I couldn't explain this, except that as we were looking at the surface of the uterus, I asked him whether or not he felt the patient had adenomyosis, because it sure looked like it to me. And he said, in fact, she probably had about a 92% replacement of her entire uterus with adenomyosis, explaining why we have such a strong signal as opposed to regular endometriosis. So those are some of the things we have to think about. And there's one other caveat, and that is degenerating myomas, degenerating fibromas can also generate a lot of prostaglandin, and as a result could give a false positive in this test.
Yes, thank you so much. There is one question from Dr. Pal Mackingham from New Jersey. He has described a French research team had developed a microRNA signature for diagnosing endometriosis through a simple saliva test. Its validation is a large cohort and could soon allow doctors to have a cheap, non-invasive and accurate tool to be used to diagnose the disease. And so for the time being, it's difficult to identify with any certainty. He has asked, how do you compare this product with that test?
Yeah, first, I'm very familiar with the test put out by the Zwieg company, and have followed it and been in communication with them. The test is not yet commercially on the market. It's available. They say it's available, but no one can actually get the test. So first, it's not available. Second, it's a very good high sensitivity and high specificity test. It's clearly non-invasive. The only caveat is I would have a hard time calling it inexpensive because it's 900 euros a test, as opposed to, and you're also going to wait 2 weeks for the results to be, for the specimens to be sent back to France to be analyzed and then to have the results sent back to the doctor. So there are time issues, there are certainly cost issues. And compared to something that's probably around $40 and you have an instant result, I think it will be complementary, perhaps in some areas.
Yes, yes, absolutely. I think the time issues and the costing is definitely going to be one of the major factor in deciding. We really need to arrive at a diagnosis at immediately rather than waiting for such a long time.
And
So
the
I
other
think,
problem, with biologicals, as we know, whether it's saliva or blood or uterine scrapings or endometrial flow, is that you have to store it properly, you have to send it properly, and so the
Yes.
resource, it's very resource intensive. So there's a lot of indirect resource costs that you don't see because of the requirements to properly store and process biologics.
I think that explains. There are most of the questions I think were about the non-invasive technique, and I think you have almost covered it in your talk. We really want to know in a country like India, where we have a lot of people having this disease, like how feasible it would be for every clinic to have this machine in their place. Will it require some installation process, or it is going to be a simple technique? We really want to know the technicalities of the machine.
So it really is a very simple device. It would come as with a computer and a monitor, and literally that device that I showed you. In fact, here's one right here. That's the entire thing. You can carry it with you in your little briefcase.
Wow.
Wherever you go. It's quite small, and the rest are just wires that connect it to the computer, and plus the consumable. So it's very, very portable. It's very, very small. And that's why I said any tiny village in the middle of a desert can be doing these tests. And that's how easy it is. So conceivably, yes. There are countries, in particular Brazil, where I spoke with the head of the Endometriosis Society and who had talked to the health minister, and they want to put this in every single one of the public health clinics throughout the country. There's about 1,004 of those. I was surprised at the number 1,004, but that's what the idea. Australia is thinking the same thing. They've put away millions of dollars just to do things like this. They put up their first 20 clinics for just that purpose. Many want to put it in pediatricians' offices, which is probably the first place that the young woman is, at least in the Western world. I don't know about what the medical structure is here in India, but the primary cares, I would think, would be the first that would see young women who had just undergone having their periods. But I mean, the ability to have that test immediately, and I mean, effectively, we go from 8.5 to 12 years to make a diagnosis in a young woman to 30 minutes. I think, sorry, it's one of the most emotional things I can think of as a physician.
Wow, Mark, I want to tell you something. We have 720 live viewers watching you on the Science Integra platform, Times of Gynecology. Thank you for being with us. So this is going to change the way the whole dynamics of endometriosis diagnosis in India over a period of time. This is some revolutionary product which we are going to cater to the gynecologist. And I'm sure over a period of time, the cost of the product will be reduced as the time goes on. Over to Dr. Komal.
Yes, thank you, Dr. Mark. I think this was a real great insight to this new technology, and there is a request from many viewers about the video which Dr. Niranjan Chavan has to play, and they all are eagerly waiting for the short video. I request you to kindly show the short video after we hand over to Dr. Ajit.
Thank you, Dr. Komal. With all the due permission, this is a video which we are going to show now for a total laparoscopic hysterectomy with bilateral salpingo-oophorectomy in a 47-year-old adenomyotic uterus having endometriosis in both the ovaries, and totally the ovaries are stuck up to the posterior surface of the uterus, and also the left ovary is totally covered by the sigmoid colon, and on the right hand side also the ileocecal junction and the appendix is also stuck to the ovarian surface. Even the pouch of the Douglas is obliterated, and this is grade 4 endometriosis in this 47 years old nulliparous woman who has got recurrence of endometriosis. I will be playing this video for the benefit of the audience as they are much more curious after Mark's lecture. Thank you so much. So this is a 47-year-old nulli gravida with adenomyosis and was posted for TLH with BSO. The uterus was bulky, adenomyotic with 8-week size. There is a grade 4 evidence of endometriosis, and there are bilateral tubo-ovarian masses with sigmoid colon and the rectum adherent to the posterior surface of the uterus. So this is what we proceed with the TLH. We see the round ligament. We use the harmonic, make it blanched. Once we have done, we also introduce pitricin because that reduces the hemorrhage. On the left hand side, we have cut the round ligament. Now we are opening the UV fold, which you can see. The space which we go also on the right hand side, and we lift up the recto-vaginal plate can be seen. There is total obliteration. Now we have separated the sigmoid colon away. This is the surgery which we are continuing on the left hand side. The uterines are taken on the left and the right hand side. Now you can see the pouch or Douglas. Now once the UV fold has been pushed down, we are going to open the vagina. Posteriorly, we go also and cut it open with the harmonic. Now this adenomyotic uterus is totally taken out. Now we close the vagina. This is vicryl. Achieve hemostasis. Close it in 2 sutures which are taken here. Following surgery, you can see this, how it looks. Now we put interseed and cover it. So this is a small video. You can go on my YouTube channel. There are 102 videos. Niranjan Chavan, and surely you will be benefiting them. I thank Hitendra and Zeba for editing this video.
Thank you so much, Dr. Niranjan Chavan, for the lovely, excellent video. And we have Dr. Rishikesh Pai join in again. We
Welcome,
want
sir.
words.
Well, so beautiful to play your that thing, no? Phone करके बोलते हैं.
They have it.
Yeah, they have the video.
Is the screen visible?
Yeah, visible. Can you
Yes.
go to the video?
We, we can hand over to Dr. Pai or Mr. Ajit.
No, I think first you just play the video and then I'll conclude.
Okay. So just play the video.
Add the sound, please.
Prediction was done by Smita ma'am, and post that she said there's a lot of harm and toxins in your body, which is causing all these problems. So she gave me Skinotox power as a treatment, first line treatment. And she said, meet me after this Skinotox power after.
Yes, welcome, Dr. Pai.
Hi, I
Yes,
hope
sir.
you guys had a great time today and getting into insights of on endometriosis and different new modalities of diagnosis and yeah, rounded up by a wonderful video shown by Dr. Niranjan Chaman on surgical aspects of endometriosis as well. So I think that we are moving towards more of non-invasive early diagnosis kind of era, and this is what my whole concept of this year is all about. It is I called it femtech. So it's technology driven,
Yes.
and more technology is coming in the form of new innovations backed by a lot of scientific tenor by a lot of researchers and backed by artificial intelligence as well. So we are going to have this new decade of exciting inventions which will effectively help in implementing good therapies at the ground level. That's what it is all about, trying to treat our patients with minimal invasiveness, early diagnosis, and effective treatment. So I will leave you at that, and I would like to thank Dr. Mark and Dr. Niranjan and Dr. Komal for wonderfully doing this program on endometriosis. And I would like to wish you all a happy International Labor Day. May 1st is the International Labor Day. And let us all think about those workers who work and toil for us throughout the year. And without them, the world would not have been that great a place. And let us wish them the very best. Thank you very much for a wonderful session.
Thank you so much, sir. And I think we are seeing all the revolutionary techniques in your presidential year, and with your theme, Badlav, with Ekikaran and Takniki, I think we are seeing technology and the AI and the newer tools for diagnosis. And this is going to make things very simpler in the longer run. And we are very thankful to you for this wonderful focused webinar on the revolution in endometriosis. I thank Dr. Rishikesh Pai, Dr. Madhuri Patel, Secretary General, Dr. Mark, who has joined, and we can see Dr. Mark and Dr. Pai together. It's such a great thing to see them both together. Dr. Niranjan Chavan for this lovely lecture, and the team Science Integra for hosting this. Thank you so much for keeping me on roll And thanks a lot for all the viewers who have come here and joined in large numbers to watch this webinar. Thank you so much.
Thank you.
The EndoSure test is the first non-invasive, objective, and highly accurate instant diagnostic test for endometriosis. Now for the first time a patient can be sure about whether she has the disease, without the need for invasive surgery or expensive imaging and subjective questionnaires. The EndoSure test uses a device called the tricorder 3L, which works by recording the electrical activity of the lower abdomen, then analyzing and comparing those values to the known digital fingerprint of endometriosis. Within 30 minutes, a diagnosis for the disease can be confirmed or ruled out. The test itself is fast and comfortable for the patient. 3 sensors are precisely placed on the abdomen. The patient drinks a glass of water and reclines. The tricorder 3L then records the electrical activity for 30 minutes. The data is analyzed using artificial intelligence algorithms. A value is produced that either confirms or excludes the presence of endometriosis. In clinical trials, data shows the EndoSure test has 100% concordance with surgical findings. All of the patients without the disease tested negative, and all of the patients with the disease tested positive. The EndoSure test is a game changer in the diagnosis of endometriosis. It will mean that patients presenting with menstrual or abdominal pains can be tested for the disease at the earliest opportunity. Additionally, the test can be used for routine post-treatment diagnostic vigilance in a cost-effective manner. Isn't it time for your patients to be sure about endometriosis? The EndoSure test is now available. For more information, please contact us by emailing info@endosure.com.
Thank you, doctors. Tech, please go offline.